Good afternoon, everybody. Welcome to this afternoon's session. My name is Reena Patel, and I will be hosting this afternoon's sessions. We're going to start with a focus symposia. Just bear with me whilst I just get my notes on that. Here we are. So I'm introducing Karen Barker, who is going to chair the session on the role of physiotherapy for people with vertebral fragility fractures. Thank you.
So thank you for coming to our session, and thank you to ATOCP who sort of hosted us. I'm going to just ask two things before we start. First of all, if you could have your phones to hand, because we'll be doing a little bit of a Mentimeter during the presentation. So if you've got your smartphone to hand, and also you will probably have noticed you've got extra cushioning on your chairs. You've got some things from the Royal Osteoporosis Society. So these are just really good guidelines, which we will refer to during our talk. So gather them up and take them home with you, because if not, I've got a lot to carry back to Oxford if I have to take them all back with me. But they are a really good resource. So thank you. So what we're talking about is vertebral fracture. This is not a sort of detailed presentation for people who are working really embedded in this field, but trying to give you all some pointers of what we've learned and what we think you'll find helpful in your practice. So the symposium, I'm going to talk a little bit about the scale of the problem and how you recognise a vertebral fracture when you're in clinical practice, particularly if you're working in sort of primary or intermediate care. Meredith will summarise the latest evidence-based guidance that should inform our practice. Then John will talk about key principles of exercise prescription for vertebral fracture. And then we'll finish off with Sarah Leyland from the Royal Osteoporosis Society, who will talk about the resources that the ROS have to support both our patients and us as therapists. And then we'll have some time for discussion and questions and answers at the end. So what do we know about osteoporosis? We know it affects a lot of people, that its impact, its cost to the economy is higher than a lot of other conditions like rheumatoid arthritis or cancer. By only next year, it will be costing the health economy £5.5 billion, and that is probably an underestimate. We know that 1 in 2 women and 1 in 5 men over the age of 50 will have some form of osteoporotic fracture. And we know that this will vary considerably. It varies with location, with socioeconomics, with ethnicity, but overall, the chances are pretty high. And we know that just on vertebral fragility fractures, there are over 66,000 diagnosed every year. And as you get older, there's an increased chance of getting one of these fractures. And when you're looking on your x-rays, I'd look to see if there was a laser pointer, but there isn't. So there are 2 different classic ones. The one on the far side, the anterior wedge fracture, and then the biconcave fracture on this side. So both of those are sort of very typical vertebral fractures. So what I'd like you to do is to get your phones out and just do a little bit of a word cloud on Mentimeter of what you think your personal risk factors are for getting a vertebral fragility fracture. If you're very young and you think, God, it'll never happen to me, think about your mother and put down what you think your mother's risk factors are, for those of you who are less stricken in years than some of us. So I think you can just scan the QR code and it should then come up with the ability to just pop some words in. That's encouraging, no responses. Tech guys? Yep. Is there any reason why we're not getting any responses coming up? I'm not sure that's why.
The message says here that Kodak presenter hasn't changed slides yet.
So what's it saying? All right, I'll tell you what we'll do. We'll try and retrieve the Menti a little bit later. For now, we can come back to this at the end because there's another sort of Menti at the end and we can hopefully retrieve these answers. I don't want to sort of spend ages faffing away with technology. We'll leave John on the end to have a play and see if he can work out what's going on. That's the only one of us who's really tech savvy. All right. So these are the traditional risk factors. So the older you get, the more likely you are to have a vertebral fracture. If you're a woman, it's more likely. Once you've had one fracture, you're more likely to have another one. If you've been on steroids or some other types of medications, such as sort of anti-epileptics, and if you smoke, all very strong risk factors. Slightly less of a risk factor, but still a risk factor, is if you drink. But those are the main traditional risk factors. And we can see from the graphic here that it really is an increase with age, both in men and women. And this is for both vertebral fractures and hip fractures due to osteoporosis. But most of these will not be presenting in a formal way. So if we look at all vertebral fractures in the green bar at the end, only 30 or 40% of them will come to clinical attention. So the idea that this is a silent fracture is really strong. So lots of people will have one, very few will come to clinical attention. So there is a really high chance that all of us are treating people who have got a vertebral fracture that they don't know about and that we don't know about. And I'm going to try and go through some things which will help you maybe recognize that one of your patients might have back pain which is due to a vertebral fracture rather than some other cause in the next few slides. And of all of those, only between 1% and 3% will lead to a hospital admission. So, we have this sort of mind picture of very debilitated people with vertebral fracture, sort of clogging up the wards, but very few actually come through to hospital-based care. So what are the characteristics of vertebral fracture? So down in Bristol, there is a really, really strong research team led by Emma Clark, and they've done lots of work with patients and stakeholders on this. So this is taken from quite an old paper, there's from 2019, but still holds very true. What they have found is that all patients will describe that they have got some form of low-level pain. They will describe it in different ways as patients do. So they will say it's a grinding pain or a dull ache or it's gnawing. They will say that it goes up and down to a crescendo, but it can be persistent, it can be intermittent, but nobody who's got a vertebral fracture who's going to present who isn't going to say they have some degree of back pain. Fairly classic for it to be vertebral fracture as opposed to degenerative disc disease, say, is this sort of feeling that the pain grows up to a crescendo and that it is associated with certain movements. So typical movements are walking, standing, leaning, and doing activities such as gardening, cooking. The most commonly cited thing that people say is doing the washing up. So if they're washing up or they're ironing, where they're just leaning slightly forward, then that is a really strong positive indicator for vertebral fracture. And they also describe this sort of pressure-like feeling. So they feel as if they've got a sinking feeling, or they're being squashed, or their stomach is a little bit constrained. And again, that is fairly indicative that you should be thinking about, has this person got a vertebral fracture? And then if we look at where the pain is, so if we just look at this graphic here, there is a 4.5-fold increase that it will be a vertebral fracture as opposed to some other back pain due to something else if you have got pain in this lateral waist area. So on the yellow bit on the outsides of the two dark lines, if that's where the patient is predominantly describing their pain, then that is 4.5 times more likely to be due to a vertebral fracture than through some other things such as degenerative disc disease. So how do they report? With vertebral fracture, the pain could have been there for days, it could have been there for weeks. It can be brief, it will improve on lying, whereas without the vertebral fracture, again, it can be months, it can be years, it may be influenced by weather, it may have pain radiating down the leg, which you don't tend to get with a vertebral fracture. Okay, so variable at the time the fracture occurs. Sort of low-level grinding pain, probably in the waist area, not going down the legs, not affected by weather, and builds into this crescendo with activity. And if you've got a new vertebral fracture and you do a little bit of percussion on it, so you sort of tap, it will be tender. Whereas if you've got somebody with degenerative spinal disease, then a bit of percussion down the spine doesn't tend to increase their symptoms. But simply asking, have they got back pain or not, is completely unhelpful. So, we all start off there, where's your pain? Give me a VAS 1 till 10, how much it is. Doesn't make any difference. It's really unhelpful. They may just say they've got pain 9 out of 10, there may be 4 out of 10. It isn't going to help you know, have they got a vertebral fracture? They may have an increased kyphosis. And again, when we think of osteoporosis, we think of, people walking around with a Dowager's hump. We sort of spend a lot of time working out how we should measure it. We, got x-rays, we're measuring their angle, or we're doing tragus to wall, all of those things. But the vast majority of people who've got a very pronounced kyphosis, it is not due to vertebral fracture. Most will be due to degenerative disc disease. So there's a very large study in the States, over sort of, I think it's about 17,000 patients. They looked at all of their kyphosis, and 90% of those severe kyphoses were due to degenerative disc disease, not due to vertebral fracture. So you see somebody, they're very kyphotic, you think vertebral fracture, they may be, but it certainly doesn't mean that they definitely are more likely to be disc disease. But what is far more helpful is to measure the rib to pelvis measurement. And that is a really simple clinical measurement. It's no equipment, you just need your hands. So you're just literally putting how many fingers can you get between your bottom rib and your pelvis? And if you look at this, we can see that if you can only get one finger between your bottom rib and your pelvis, then there is over 50% chance that you have got more than 2 vertebral fractures. Conversely, if you can get 4 fingers in that space, there is less than a 1% chance that you've got a vertebral fracture. So it takes no time to just measure your rib to pelvis distance with your fingers, but is a very, very helpful indicator about whether or not you may have a fracture. The VFRAC is a clinical screening tool that is being rolled out more and more. Again, this is entirely based on a consultation with the patient and the clinician. Doesn't require any prior X-ray. It has questions in it that are very predictive. So if people say they had a fracture after 50, they say leaning forward, doing things like chopping vegetables, washing up, makes it worse. If it's better when they recline, if it's worse, if they sit on a straight back chair, their pains in the thoracic area, all of those things are very positive predictors. On the other hand, if their pain is worse by sitting on a soft chair, if they describe it as like toothache, if it gets worse with walking, if it's in the low back or buttock area, then that is less likely to be a vertebral fracture. So the VFRAC takes 5 minutes, and it's probably a far easier clinical tool to use than trying to do a VFRAC where you need a lot of other information. So I hope that has given you some pointers to how to look out and see, well, have I got a patient who I'm not entirely sure what it is, might be degenerative disease, might be a bit of vertebral fracture, might be both. And now Meredith will talk to you a little bit about the evidence-based guidance of what physio we should be giving them.
Thank you, Karen. So I'm Meredith. I'm going to talk about the evidence for physio. And actually, this is a really exciting area to be working in. There's been a lot of new evidence, and in the last 4 years, we've had new consensus-based guidelines out in the UK, which we have a copy of, but also in Canada and from the International Osteoporosis Foundation. And what they're suggesting is that we should be considering recommending referral for individualised physiotherapy program for these patients. And what does that program look like? It's a multi-component program. So the consensus is that we should be looking at exercise and focusing on back muscle strength for posture and pain, focusing on bone health in terms of keeping muscle resistance exercise, weight bearing and impacts, that strong element, and balance and muscle strengthening again to keep people steady, prevent falls. Where do we start? Well, we start on the strong part of that and straight part of that for most people. Okay, and the reason is, if we go back to that hyperkyphosis that Karen is talking about and support for the spine, we know that hyperkyphosis loads the anterior vertebral bodies. The anterior vertebral bodies are a little bit less dense, the anterior part, and they're more susceptible, therefore, to deformity, to fracture. So we're wanting to reduce load, we're wanting to support the person and prevent another vertebral fracture, or something we call the vertebral cascade. And we know that in the year after an incident fracture, there's a 12 times increased risk of having another one. So through this mechanism, but also because kyphosis obviously disturbs our balance and you're more likely to have a fall and have a non-vertebral fracture. So we really hone in on that straight area and strong in the beginning. Karen's talked about this. I like this slide because it reminds me, again, that vertebral fracture is only one contributory factor to hyperkyphosis. And the most important things are modifiable. So back muscle strength, pain, stiffness, those factors which are modifiable with physiotherapy. So is it effective? Okay, these are the sorts of exercises we would be doing for this patient group. So exercises and stretches, active range of movement to improve trunk extension, shoulder flexion, cervical dorsal glide, hip extension, then progressed resistance training that targets your erector spinae and your hip extensors again, and sort of postural awareness really through daily life. So, breaking up long periods of static sitting, which we should be doing anyway, long periods where we're loading that anterior vertebral column, we're sitting in a kyphotic posture. So the evidence is that kind of program, probably the largest amount of evidence comes from our PROVE trial, which we took 615 people, mainly women. We looked at them in 3 groups. Some had manual therapy, some had more exercise physiotherapy, which was the sort of strengthen program we've talked about, and then compared that with a single session of education. And what we found is that with a 12-week program of about 6 sessions and a home exercise program at a year, we saw improvements in kyphosis. So the largest improvement was in that exercise group. We did get improvements, small changes in the other ones. My colleague Erin led a secondary analysis of the PROVE data where we put all the groups together and we asked ourselves a question about kyphosis severity. So when people have a more severe kyphosis, they're more likely to have more fractures, and that's, if you like, more fixed elements to the deformity. Would they change? They're also more likely to be older. Could they benefit from this therapy? Okay, there's a bit of a debate out there. And what we found, in fact, is that only those with hyperkyphosis had significant improvement. So if you weren't hyperkyphotic, it's stabilised, which is perhaps a good outcome anyway, but the extent of improvement really was linked to how kyphotic you are, and those changes would persist to 12 months. Okay, after a 3-month program. So this is a really encouraging finding for physios. If we look at that evidence across the world with other trials, So these are 3 trials with very homogeneous kinds of interventions, the kind of intervention I was just talking about. And as you can see, this is immediately after a 12-week intervention. We can see about a 5-degree change. And what I find interesting in these trials, they also measured back muscle function using something called the time-loaded standing test, which is a really clinically friendly test. It's about 1 kilo weight, there's Townsend's got. And we see an increase in back muscle strength and endurance in parallel in each of these trials. So one of the mechanisms of effect really is probably that this is we're strengthening their muscles. So if we think about pain, which is that other element of the straight circle, there is less evidence in this area. There's less consistency in ways it's measured. There are 5 studies that use a VAS scale to measure pain, and there is some evidence that it significantly decreases immediately after treatment compared with a control, about a 1.5 point change on a VAS scale. What's perhaps more interesting, I think, about this is that they did a subgroup analysis and they looked at studies that had interventions of more than 10 weeks versus studies that were doing interventions of about 4 weeks. And the 2 of the 10-week or more interventions, they were significantly better, more effective than the shorter interventions. But I think we need more evidence here. The third thing we talked about was like postural awareness and spine caring techniques. So one of the things that we talked about is that discomfort with people sort of forward bending in those, washing the dishes, hoeing or whatever in the garden. And something that physios teach here is something called the hip hinging technique, which is bending through your hips with a neutral spine. So if you're brushing your teeth, bending from here rather than bending through and increasing that kyphotic on that load through the vertebra. This is a great website. That's the Canada osteoporosis website, and they have pictures of physio teaching hip hinging technique, using that sort of patient using that to actually sweep up in the kitchen. So I'd really recommend that if you're interested in finding out about that. We also recommend sort of doing quite a bit of, task analysis, asking what people are doing, using our moving and handing ergonomic kind of principles, whether it's, in the garden, that kind of thing. Okay, so I'm going to think now more about the strong. Can physiotherapy improve function for this patient group? So there's multiple trials that have measured this in many ways, and each of them in their individual ways. So whether it's functional walking capacity, the short physical performance battery, chair stands, we do see benefits reported. There was a systematic review in 2019, a Cochrane review, and that concluded that we could be moderately certain that there was a significant improvement in physical function, but it was perhaps relatively small. More recent review, which has got a bit more data in it, but also confined its study population to studies that did resistance, so strengthening and balance training, okay, not to other kinds of therapy. And they found, using the timed up and go there, a more significant impact, and that would definitely be a clinically relevant change on a timed up and go. So we're thinking again about that strong diagram. We need to think about impact exercise. We know that impacts are very osteogenic, okay, we're trying to maintain bone health. And the recommendations consensus is most days to include exercise that has weight-bearing impacts in it. What kind of level of impact? Well, there's a real debate because we don't know what the sort of load that can be applied to osteoporotic bone safely is. The consensus is definitely that lower impact exercise is safe and recommended for everyone. Okay, so that's, heel drops, step ups, brisk walk, those kinds of lower impacts. There's some evidence that moderate impact exercises may be safe for some, and this is where you would need to, use your clinical reasoning. Was this a fracture that was picked up incidentally as a scan for something else. It's not symptomatic. It's not painful. Is this person osteopenic? So they have a little bit of low bone mass, but they're not osteoporotic. What's the severity of the fracture? Is it a minor change? And if there's people familiar with the exercise, they're doing it with a good technique, we might be more confident of them doing, increasing up to moderate impacts. Okay. There's some studies that have looked from Queensland, have looked at high intensity resistance and moderate impact training. So this is the Liftmore trials. And so the first one, it's a wider trial of 101 women who are osteopenic or osteoporotic. Some of them did have minor vertebral fragility fractures. They didn't have any back pain. They weren't recent fractures. They scanned with a DEXA scan, 51 of them, pre and post this intervention to look at what happened. And it was an intervention where a physiotherapist did an 8-month intervention twice a week, really low load and teaching technique, and then gradually increasing exercises like deadlifts, squats, overhead press, and you can see. And at 1 year, that group didn't have any new vertebral fractures, compared to an inactive control group who weren't loading at all, so not even low loading. They looked a little bit further and did an exploratory study really with a younger group, but just men, and they compared high resistance, same intervention, with like machine isometric load, high resistance training. And actually in this group, at the year, although they didn't have any new fractures in the physio-led one, they did have 5 new ones, and they're 20 people, which is 25% of their people did have new fractures at the end of a year. The overall message for me in these studies is that none of them were powered to detect vertebral fractures, okay? So we don't have enough data. And we don't actually particularly know about the kind of risk these people were at of having another fracture. So we need to know things like how recent the fracture was, because we know, for instance, in that first group, the control group had 11 fractures in it, and the intervention group only had 6. So we'd expect our control group to be at a higher risk of having a fracture anyway. So we need to really gather data in this space. But at the moment, the consensus is that the evidence perhaps doesn't support high intensity loading for this group. So think about that third area, staying steady. What is the evidence here? I think it's really helpful to put this in context for this group. So, at least 30% of adults over 65 report falling in a year. And our current trial, which we're just analysing, just finishing, which was with 126 adults who had at least one vertebral fracture. We asked them at the beginning of the trial, have you fallen in the last year? And actually 46% reported falling. So that's, you're right. And then of those, 30 of them had to attend A&E or see their GP. So this group is at a higher risk of falls and harms due to falls. In terms of whether physio can be effective, our biggest evidence really comes from wider studies about falls in older people. And many of whom will have had a vertebral fracture, even though they don't know it, just because of the prevalence of vertebral fractures. And what the evidence here suggests, and it's a really good Cochrane review by Kathy Sherrington, if you are interested, is that we can be highly certain that functional, and strengthening and balance exercises reduce the risk of falls by about 24% versus an inactive control group. If we add balance, functional, and strength training, we get we're sort of moderately certain that we even get a further reduction in our fall risk. What I found particularly encouraging was that they did a subgroup analysis and they found that programs led by a physio or healthcare professional, which was sort of 90% of whom were physios, were more effective than those led by non-physios. They weren't very certain that if you do one type of exercise, so like if you do dance or you do walking, that did have an impact on falls. So it seems these multi-components are really important. Do we have evidence in people with vertebral fractures? Well, at the moment we have evidence about balance, okay? Trials investigate balance in multiple different ways. They usually deliver sessions about twice a week and measure it using sort of something like the dynamic balance using a functional reach, which you can see there. Or they might measure something like the 4-square step test, the short physical performance battery, or balance platform. So when we look across the patch, yes, they're all reporting immediately after treatment improvements in balance, but we don't at the moment have evidence about falls because we don't have the longer term and the large enough studies. So that's a quick whip through. I'm going to hand over to John now.
Great, yes. Good afternoon, I'm John. So we're going to have a think now about exercise prescription and tailoring to the individual. So you see here a leaflet from the International Osteoporosis Foundation, and you'll note they've used 3 images there, and they really, they lend to people thinking about exactly what you've heard before: weight-bearing exercises, muscle strengthening, and exercise in relation to posture and balance. So we're going to think about general principles, and from the outset, I think we need to say that it's important that we are reassuring to patients that there's little evidence of harm, and that would include risk of further fracture, which is something they're likely to be concerned about. We need to take an empowering and reassuring approach, and to move from a don't do to a how to approach. And that takes a bit of a change of mindset. I know certainly in my working lifetime, I've definitely had to move from one kind of mindset to another. So from a don't do to a how to. In thinking about general training principles, so bear in mind we're starting with general principles here. This is a zoomed out view before we zoom back in on those with vertebral fracture. Key considerations are for exercise in terms of optimizing bone health include loading. So we know that high load applied rapidly, or dynamic load, or new patterns of applying load with short intervals of load with rest can all help. However, please remember what Meredith just said. We need to be careful with applying too much load to this patient group. And so please don't forget what you've already heard. We know that the principle of reversibility matters in bone health, much like it does with broader exercise prescription and other patient populations. The same for specificity, which is always going to be a struggle to say. Adaptations that we see are specific to the site or the area under load. Again, we see loads of ideas and concepts that are similar to exercise prescription more generally. And so progressive overload matters. Our load needs to be above that which is caused by habitual activity. We know that for those starting with a lower bone mineral density, they have the greatest potential to be gained. And that's exactly the same as, like, I think about that as exactly the same as with physical activity. Like, those doing nothing have the most to gain by doing even a little bit. And the same is here is true with bone health. And finally, we can think about diminishing returns. So thinking about bone accommodating to our exercise or physical activity program. So we need to consider those broad concepts and funnel them down to the individuals that we see. And, you know, physiotherapy is all about patients. It begins with people and it ends with people. We don't want to forget the individual in front of us. So we do want to take general principles, but we want to consider individuals. Hopefully, oh, that is not the slide I was expecting. Here we go. Hopefully you've heard of the FIT principle, but, you know, If not, here you go. This is thinking about fit principles, but for those with osteoporosis. And so in terms of frequency, we know that there's a need to be active most days, but for 3 or 4 days at least. For intensity, we're looking to see exercise at a moderate level, and we could use something like the RPE scale, and we'll have a look at one of those in a mo. And time-wise, we're thinking about 30 to 60 minutes a day, and that can either be in one go or broken down into 10-minute sessions. And type, we're interested in weight-bearing exercises using large muscle groups. We're interested in mixing strengthening and posture and balance. If you want to go and have a look more at this information, it comes from Exercises Medicine, Exercising with Osteoporosis. I won't dwell on this for much, but this is fit principles if you were to go back and look at the ACSM guidelines for exercise prescription in clinical populations. And all I want to say is it's fairly similar, despite the more than a decade between the publication of both of those. So in terms of intensity, here's an example of an RPE scale. You may choose to traffic light, you may not. But what we're looking to do is get people working at that somewhat hard level. For an example of how that might be used in a trial, I'm not going to say anything more about opt-in other than watch this space. You can see here that we can think about, do we need to make things easier? Do we need to make things harder? Or do you know what? Are we just on the right track? And so kind of that traffic light system helps there. In terms of principles of resistance training, we know that, again, we just need to bear in mind the patient group we're thinking here, because we know that resistance training can be really helpful. And again, we see that kind of like high load here in this slide, but this evidence is taken from people with osteoporosis and not people with fragility fracture. And so we need to be careful, but the basic thing to say here is it's okay to give people resistance training. Like, it's an okay thing to do. So we can see here some examples of different types of weight bearing, moving from sort of low impact to high impact. I wonder when the last time is you prescribed dancing, possibly with jumps in one of your sessions. But it's just to say there will be something for anyone. There'll be a starting place for any patients that you're seeing. And the same thing with strengthening. We can think about different ways of strengthening, and there'll be a starting place for anyone. So in terms of exercising after vertebral fracture, all patients should be considered for an exercise program. And we might need to think about the timing of that, like perhaps going up to them day one on the ward might be a little bit harsh, but all patients should be considered for an exercise program. And you can see a little bit more about timing within that slide. And the focus, as has been mentioned, needs to be on weight bearing, strengthening, and balance. In terms of tailoring to individuals, we know that to tailor something to somebody, you need to know something about them. If you don't know anything about them, you can't tailor anything to them. And so there are parts of our assessment that might pick that up around exercise history and current habits. But I think we need to be careful of not glossing over those things, particularly because in terms of some of those higher risk activities that we might want to modify or change, that could be stuff, again, like related to loading or sustained end range positions. But we might want to think about the individual. So if your patient said to you that their goal was to go skiing, your question might be, have you ever skied before? And if they say yes, maybe there's a good chance of that happening. And if they say no, then it might be a slightly different conversation. So we've got to know something about the individuals that we are wanting to tailor to. So here's an example of some exercises individualized by patient ability for trunk extension. And simply that is there to say, there's a place that everyone can start at. There's a place that everyone can start at. If we're thinking about balance, I suppose just to say, if people are falling repeatedly, they need to be referred to the appropriate service. So we need to just get that sorted. But we want to challenge balance appropriately, but we want to do that safely. And in terms of thinking about what kinds of exercises, that in itself might be multimodal as well. So thinking about static balance, dynamic balance, or even combining with some of our resistance and functional exercises. We know that class and individual formats might work. We don't know which is the most effective. And I guess the positive way of saying that is whatever you choose is fine. We also want to think about the uptake and maintenance of exercise. Like, we can prescribe the best exercise program ever, but if it's not done, it's unlikely to be helpful. And therefore, we're going to want to think a bit about maybe behavior change or behavior change components and interventions. The image on the right is the behavior change wheel, and in the middle of that is the COMBI model, which simply says that for behavior to take place, the individual or the people involved need to have the capability, the opportunity, and the motivation. You can break those down into further subdomains, but essentially it's saying that there are multiple domains to behavior, and some individuals might be struggling on one of those domains, but the next person you see, it might be entirely different. And if we understand something about that, we might be able to tailor some approaches, whether that be things like cueing or reminders, or it might be action plans or coping plans. Like, what we're going to do will differ depending on perhaps where they're struggling. And the image on the other side of the screen is where that was tried with patients with MSK problems, older patients with MSK conditions. And it showed that it's feasible for physios, even though they're not psychologists, to be able to tailor exercise adherence or behavior change approaches to individuals based on thinking a little bit about COMBI. And so I am going to finish there by saying we can think about great exercise programs, but let's not also forget behavior change approaches, seeing people as individuals, meeting them where they're at, and then really helping them with some of that structure and support around the exercise.
So our next speaker, as is always great when you're organising these sort of symposiums, couldn't be with us. So luckily she has recorded her session for us. So we're moving on now to Sarah Leyland, who is one of the sort of patient advisors working for the Royal Osteoporosis Society, and is one of the reasons why you're all sitting on top of her leaflets.
And we decided at the charity that we didn't just want to provide an update of the information we already had, but we actually wanted to go back and look at some of these deeper questions. And we wanted to produce guidance for healthcare and exercise professionals as a starting point. Just as a reminder, really, I wanted to show you the 3 themes that we began to develop information and guidance under, and these were strong, steady, and straight. And that really was information around bone strengthening exercise, information about exercise to reduce falls, and advice and recommendations around moving and lifting safely, which wouldn't cause an increase in the risk of spinal vertebral fractures, and also exercise to help with those pain and symptoms caused by vertebral fractures. So these were the 3 themes. And perhaps it's important to say that there was a lot about our work which was about boosting confidence as well as improving quality of life. So we wanted to actually not include any voids or can'ts in our information. We wanted to give people positivity and confidence to continue doing the exercise that they enjoyed, because there was a lot of fear and anxiety around, particularly when people had had a diagnosis of osteoporosis, that any kind of exercise was unsafe and might cause fractures in the future. So that was one of the key principles that came out of the work that we did. So now let's move on to talk a bit about what are the resources that we produced, and they still are available. In fact, this consensus statement that we wrote is available in a hard copy here at the conference, so do look out for it. The full document and indeed the quick guide can be downloaded from our website, but there is the opportunity while you're here to pick up a hard copy. So this consensus statement on exercise for osteoporosis It's called Strong, Steady and Straight, those three themes. And it really does set down where is the best evidence, where is the consensus expert view in terms of optimal exercise for bone strength, for reducing fractures, for reducing the risk of falls, and for looking after and caring for your back. One of the useful component parts of the quick guide is there is a flow chart in there, and I've just given you a quick glance at it on the screen now, which allows you to think about the patient in front of you and what are their particular needs. And are they interested in information about strengthening their bones, or is it really much more about reducing their risk of falls? Or have you got someone who really needs help around caring for their back? So do they need advice about moving and lifting? Do they need to build up their confidence about what they can and can't do? And also, do they need exercise to help with pain of spinal fractures and the curvature caused by multiple vertebral fractures? So that's a really useful part of the quick guide. And as I say, it's something that you can download or pick up at the conference. So these are resources for the public, for your patients. And as a great starting point, we have a fact sheet, which is called About Exercise for Osteoporosis and Bone Health, which really takes you through all the general information about what is the role of exercise for those with osteoporosis and for those looking to strengthen their bones and reduce the risk of future fractures. And we also have two short films with warm-up and cool-down exercises and a getting started fact sheet. And last year I worked with the team on producing a film specifically answering some of the safety questions. So a really popular resource that you might want to point your patients towards. Other resources that we have a 20-minute film which specifically focuses on bone and muscle strengthening exercises. And the great thing about this film is that it's not only aimed at people who are the fitter, healthier person with osteoporosis or person looking to increase their bone strength, but also there is one of the patients working with the physio is someone who's had vertebral fractures. So the exercises are tailored to meet her needs as well as the fitter, more able person. And there is a fact sheet that goes alongside this short film. Last year, we set out to produce a whole range of new short films, much shorter actually, they're just 3 to 5 minutes each, really looking to work with those who wanted more detail around how can I build up weight-bearing exercise, impact exercise, how can I build up muscle strengthening exercise to help promote bone strength. And we produced 4 short films on each of these topic areas. So there are 4 short films on building up impact exercise, an introduction, stage 1, stage 2, stage 3. And within that, there are very specifically chosen exercises. As I say, we worked with academics in the field, looked at the evidence, and there are 3 exercises within each stage that people can focus on and practice to gradually build up. And the idea is that if they're well enough, they can build up to the moderate type impact exercise, which is probably the best we can do for bone strength. Recognizing, of course, that those who have spinal fractures may well be advised to stay at the lower impact end of the range. But there is the option here for those who are more able to build up to moderate impact. And then there are also 4 films on building up muscle strengthening exercise, recognizing that it's really the progressive muscle resistance exercise which is going to be best if we're going to promote bone strength alongside the impact exercise. And we worked again with experts in the field, building up a stage 1, stage 2, stage 3 with an introduction at the beginning. And what we recognize here is that in order to work all the main muscle groups in the body, it was decided there should be an exercise in each of the 4 groups: hinge, push, pull, and squat. And so what has been set out here is an example of an exercise in each of these different groups fitting within stage 1, stage 2, and stage 3. So there is a progression. For instance, in stage 1, the hinge exercise is the bridge, the push exercise is the wall press, The pull exercise is the band-assisted row, and the squat exercise is the sit-to-stand. So as you progress through stage 1, stage 2, stage 3, you get an increased intensity in the exercises that are suggested. And in addition to that, we produced a short film on how to use resistance bands and a short film on how to use weights. So really useful basic information for people who wanted to build up the right kind of exercise for bone strength. And finally, there is again that film on exercising safely, which answers many of the questions about what is right for me. And that, as I say, will also cover those who've already had spinal vertebral fractures and want specific advice around that. There are also some extra exercises included at each stage to kind of help the body get ready for the more intense exercises that are in the section above. So an exercise in a group called brace, a lunge exercise and a step exercise, all helping very much to prepare the body for the more intense exercises in the muscle strengthening section. So what about those people who perhaps are at the less able end of the spectrum, who particularly want to focus on exercise to increase steadiness and reduce the risk of falling? We know that many fractures are, as you know, linked to the risk of falling. So we have got a film called Keeping Steady, which is sets out all those well-acknowledged exercises to help improve balance and coordination and muscle strength and reduce the risk of falling. And we have a fact sheet to go alongside that short film. Finally, we have a whole range of fact sheets and short films that focus on the caring for your back, the spine caring approach, as we call it. So there are short films on moving and lifting safely, bending forward, a lot of the questions around Pilates, perhaps to a large extent reassuring people that if you've got osteoporosis, then there are sensible things you can do to amend some of the exercises, but many of these movement and exercise regimes are very safe if you're doing them properly. So very useful how to modify should you need to film, but also a very positive one on Pilates. And then we have two final short films, one on exercise for back pain, exercises to help with posture, and a fact sheet to go alongside those. So that's really taking you up to date in terms of the strong, steady, straight exercise resources that we have at the ROS. But I did just want to mention another whole range of fact sheets. None of these are new, but they're still really useful, I think, to help patients who are living with the symptoms of vertebral fractures. We have a booklet for those who don't really want to use online resources. And then we have fact sheets, and they really cover a whole range of issues faced by people who are struggling with pain or with changes in body shape due to osteoporotic spinal fractures. Daily living, out and about, travel insurance, employment, social care, caring for someone with fractures, financial help, clothing and body image. So all sorts of information which you may find will help you. And two others, one on exercise after spinal fractures with a physiotherapist, and one with a postural stability instructor on keeping moving to stay active. So really aimed at people who are less able to do intense exercise and want to know where to start. And last but certainly not least, I just wanted to remind you of the other services provided at the ROS for your patients. So we have a free specialist nurse-led helpline. We run local support groups still. We have our new online community forum offering peer support. We have our membership, not forgetting our professional membership in case you're interested in that too. We have our website. We have leaflets for you to use in your clinical practice. And last as well, I wanted to mention our new online medication support program, which we will be launching next year.
Right, so we're going to skip over Menti because John can't, he's told me it's not going to work. And I understand we've got a little bit of a change. So we're moving to Erin, who's going to give her presentation, and then we'll do the sort of Q&A for both her presentation and ours at the end. So handing over to you, Erin, hoping your slides will load up.
Thank you, Karen. There it is. So my name is Erin. I'm part of the physiotherapy research unit as well. And I will be talking about my research, which is closely linked to what we just learned about today. So we've had an opportunity, they've given a great background to vertebral fragility fractures. And again, they're prevalent. At least 1 in 5 older people will have them. They're associated with other factors such as pain, reductions in physical function, and reduced quality of life. So once we use all the recommendations that we've just heard about and we're treating these patients, we want to know if they're getting better after our treatments. So this is where this bit of research into the minimal clinically important difference comes into play. So we want to know when we're measuring before and after, are these are we making a change that is actually important to the patient? So we aim to estimate the MCID for the TUG, the timed up and go test, and the QoL-FO for this clinical population. So first of all, we've heard a bit about the opt-in study. This bit of research was embedded within the opt-in study, the osteoporosis tailored exercise adherence intervention. And we included participants from both arms because both arms in this trial received an active exercise intervention by a physio. And we measured these outcomes before, so at baseline and at 4 months. And just a bit about the timed up and go. Most of you will be familiar. It's a very practical test. It's a time test where the participant stands up, walks 3 meters, turns around, sits down. And the QoL-FO is an osteoporosis specific questionnaire, and it ranges from 0 to 100, but 0 indicating the best quality of life. And on to the methods. So if you're not familiar with MCID methods, there's no gold standard, but the most accepted is anchor-based methods. So with anchor-based methods, we need anchor variables, and these are to represent true change. So for the TUG test, we used both the global rating of change for walking and balance and the physical function domain of the QoL-FO. And for the QoL-FO, we use the global rating of change for their quality of life, as well as the EuroQoL health score. So along with the anchors, we use different methods. So we were reporting here on 2 of the methods. So the change difference is the average change score of the responder participants. And these are the participants, the group of participants that got better according to the anchor variable. And then you subtract the average score of the non-responder participants. The next method we used was the ROC curve, which is a plot of sensitivity against specificity and finding that optimal point where those are both maximized. So if we look at our patient group, most of them are female. The average age is over 70 years old, and the average number of fractures is over 2. And so the MCID for the TUG was estimated to be 0.5 seconds to 1.1 seconds reduction. And the MCID for the QoL-FO, 3.3 to 5.4 points reduction, so an improvement. So we've used these different methods to triangulate, get an estimate of the MCID for the TUG and the QoL-FO. And clinically, this means that we have a marker of what we would find as an important measure of change after treatment. And from a research point of view, MCIDs can help inform sample sizes and important outcomes in rehabilitation trials. So thank you, and a quick acknowledgement to the Chartered Society of Physiotherapy Charitable Trust that funded this bit of research.
Okay, so I think we're now going on to questions and answers for anything that you've heard in this sort of session on vertebral fracture. And there's some weird looking orange box over there, so
Hi, I work in a community team in Shropshire. My question is regarding the timing of physio following vertebral fracture and how long should it continue for? So the background to that question is that I see a lot of patients at home with vertebral fracture. They haven't touched hospital. They've been potentially diagnosed by the GP. They're in a lot of pain. GP has often prescribed morphine-based painkillers to manage the pain. Moving anywhere is very difficult. So is there any rules about, don't do this for the first 2 weeks, or do I just go ahead? There we go. That's my question.
Right, okay. So there is no contraindication to starting to do something with somebody as soon as they have had a fracture. But realistically, when the pain is really bad, and particularly if they're on a lot of morphine, you're sort of counteracting the fact that they're sort of, dozing off. And and in most areas, we've got a limited resource. And so when are you likely to be able to give sessions which will be at their most effective is probably from 6 weeks onwards, when they've got over the initial very acute pain. And from 6 weeks, they're starting to heal, and then you're likely to have more benefit. In the first 6 weeks, it's just important that they keep moving. They don't just, retreat to bed or the chair and, sit very still and in a lot of pain. So I'd say general movement in the first 6 weeks, and then the time to start doing formal exercise based is between 6 and 12 weeks and on from there.
I think you asked another part, wasn't it? Was just how long they should continue. So what we see is most interventions that are studied are at least 3 months, but that could be, individual sessions spread over that time.
I think we got a question on the online.
Asked, how important do you find advice on exercises to avoid, such as crunches? So
things like sit-ups or crunches, they are adding high levels of load to the vertebral body. So they'd be sustained high load exercises. So crunches, Pilates, extreme flexion, and those are exercises we would want to take out of a program and substitute with something else, a plank or similar, or a pelvic tilt. So we wouldn't be doing high load.
I think, it's probably helpful. Is that on? I don't know. It's probably helpful to say it's just about modifying exercises within programs. Like the person doesn't have to stop going to Pilates. They don't have to stop going to the class that they love, where they meet with their friends and they exercise together. They don't need to stop doing that, but they might need to modify some stuff, and particularly those sustained end range positions, high load. Well, let's modify that and say, get on and do the things that you love, but just do it a little bit differently. I think they're deliberately doing it in the furthest part away.
Great presentations. Thanks very much, team. Apologies for asking you a question that perhaps didn't come up in the talks, is thinking about how we implement this rehabilitation in a one-to-one setting versus a group setting. If we're going to do this in the NHS, is there some benefit in group-based rehab?
Yes, so within our own department, we have an osteoporosis group. And I think one of the benefits of that has been that the patients form their own sort of support group. So often, they come, they do the exercise, then they all go to the League of Friends Cafe afterwards. And certainly some of them sort of graduate from coming to the group in the hospital and will transition to, we have something called Generation Games, which is exercise classes for older people. So I think groups have their place. I think, obviously we've drawn on a lot of the research evidence, and, it's harder to research on groups than individuals, but we do both. So, there are some people who need individual treatment before they can maybe graduate to the group and stay with that for a while and then graduate out to the community. Some people will put to a group straight away, and to some extent it depends on that initial assessment about what the patient's preference is.
Hi, I'm Nicola. My question is just around medication, in terms of, is there any considerations for those that are high risk of fractures that we should be ensuring that they're on the relevant medication prior to, kind of the length of time you would expect?
Yeah, so I mean, there are quite well-defined algorithms for the medication that people are on. So if they've been referred by a full service, or if they've had a DEXA scan, then they would usually be on some form of biphosphonate, and then there's a sort of algorithm depending on how well they tolerate those. So you need both. I mean, if you look at the patients, most patients will be on some form of biphosphonate to improve the pharmacology aspect to their bone health, but exercise then is something that works hand in hand with that. And then there are, again, if we go on to either the International Osteoporosis Foundation has a really clear sort of guidelines to the evidence, or the ROS has a booklet about the management of vertebral fracture, which goes through the algorithm of pharmacology for it. But as physios, it's just about checking, are they on some form of biphosphonate, rather than getting bogged down about, are they on this a lab versus the other a lab versus denosumab versus what have you. But yeah, they should mostly be on something. A lot of them, once you've been on it for 10 years, you have to have a break from it, so they'll be on nothing if they're in that sort of maintenance period. But I think it's just being aware what they should be on.
Thank you. Did you have a view around vertebroplasty and kyphoplasty and the role that plays? And the GIRF guidelines kind of last year or year before suggested it was used at the front end, whereas previously it was used at the back end of pathways. So where does that fit, and when should we reach for the cement?
There's quite a lot of politics on kyphoplasty, vertebroplasty. There are some people who would say, particularly for those patients who are admitted with vertebral fracture, which is really, really painful, that rather than getting to that cycle where they're on opioids and you can't mobilize them, that actually doing some form of augmentation procedure will get them up and get them mobile quicker. I think if you look at the research evidence, it is, I think, let's be kind and say it's emerging. I don't think that there is strong evidence as yet for vertebroplasty or kyphoplasty, but the people who believe in it very strongly and advocate very hard for it. I think, it's emerging still, is probably the best I can say.
Just regarding the vertebroplasty, if somebody then decides in your area, a radiologist maybe, that they will provide somebody vertebroplasty, would you then change any of your physiotherapeutic management? Sorry.
Yeah, there are trials which have vertebroplasty and exercise, and and again they would be starting with those muscle strengthening exercises, but back strengthening. But if you're somebody in hospitals, it's generally a functional mobility approach, getting somebody home. What we talked about before in terms of pain management, 6 weeks plus, you'd be looking to introduce and go further.
But you've had your vertebroplasty, you've still got the underlying osteoporosis disease, so you're still going to need to follow a program of strengthening stability exercises. All the vertebroplasty has done is treated one very localized area. Thank you. Right.
So my thanks to Karen, Meredith, John and Erin. Please join me in just a round of applause. Thank you very much. And if there are any further questions for the panel, I'm sure they'll be around at the break. I'd now like to introduce Yasid Kashwa, who is going to share his research on functional activities during which the community dwelling ageing population in the UK may experience near falls, a modified Delphi consensus development study. Thank you.
So thank you very much. Good afternoon. My name is Yazid Kashwa. I am a doctoral researcher at Queen Margaret University. I'll be presenting over the 10 minutes to come my part of my doctoral studies. I'm supervised by Doctors Judith Lane, Chiwi Tan, and Joanna Long. And I'll be talking about the functional activities during which the aging population in the UK might experience a near fall. So near falls are when somebody loses their balance, such as a trip or slip. As we know, falling is the second leading cause of death worldwide amongst older adults. In the UK, 1 in 3 people experience at least one fall a year. With this in mind, the National Office for Statistics predict that 1 in 4 people in the UK by 2050 will be aged 65 years old or older. And falling actually doesn't only come with high mortality rate. The costs for falling to the NHS alone reached the region of 2.3 billion per year. And a seminal piece of work outlined that, which actually included 20,000 participants, that there is a sharp increase in the prevalence of falling from the age of 50. And psychosocial aspects of falling were found in 85% of people experiencing falls, and were found to be associated with higher risks of falling. And a key aspect of psychosocial falls are falls self-efficacy, which is to do with the individual's perceived ability to maintain their balance. But to understand this further, let me take you to the next slide here, which is to do with the stages of falling. We can see here the near fall stage, where an individual, as I said before, is subject to a slip or trip or any other sorts of loss of balance. At this stage, the individual could regain their balance. They could either regain their balance successfully to avoid having an actual fall, or if failed, unfortunately, they would then proceed towards the full landing and completed falling stage, which understandably would be associated with higher risks of injury. And it's also worth noting that near falls were found to be good predictors of actual falls. So ideally, what we'd hope to have is a patient-reported outcome measure to assess the people's confidence to regain their balance if they lose it. In 2022, a research team from Queen Margaret University developed the world's first balance recovery confidence scale. And that was in Singapore and contained 19 items. But before we apply this to the UK context, it's important to establish two things: relevance, as in how relevant are the existing 19 items to the UK context, but also comprehensiveness, which is a question of, are there other activities that would be relevant to people living in the UK? So what did we do? Asking the experts. We did so by carrying out a modified Delphi study. And for those who are not familiar with this type of research, it is a consensus development method for which I carried out electronic surveys. Our experts were healthcare professionals with 3 or more years of experience in falls management, and of course, the people themselves. People aged 50 years and over who live independently in the UK. We recruited our experts using purposive sampling through gatekeepers and snowballing. So for the question of relevance, what we did was presenting our experts with the existing 19 activities and asking them to rate them on a scale of 1 to 9. So 1 to 3 was considered low relevance, 4 to 6, moderate relevance, 7 to 9, high relevance. When it came to comprehensiveness, we provided our experts with a text box so that they can suggest any other activities that they feel would be relevant to the aging population in the UK. We analyzed the data using Erlingson's and the Brezevich thematic analysis. Basically, it includes condensation, coding, categorization, and theming. So, in fact, we had responses from 80 experts, 55 healthcare professionals with 720 years of experience in falls management alone. And on top of that, 25 community dwelling people with a mean age of 66 years. And actually, we had representatives over all the 10-year bands from the age of 50 and 92. And we can see across the healthcare professionals the diversity in the professions: physiotherapists, nurses, physicians, and occupational therapists. So with regard to the relevance, we actually found out that 13 out of the 19 activities developed in Singapore were relevant to people living in the UK. 5 were moderately relevant, and only 1 was reported low relevance. When it came to comprehensiveness, 128 activities were added by 44 experts, and following qualitative analysis, a final list of 27 activities were reported or formulated. So the big reveal: what are these 27 activities during which people aged 50 years and over living independently in the UK might experience near falls? I'll do so by presenting them in over the next 3 slides. So it's each group, a group of 9 activities in each. So this is the first group. I'll leave this slide here for a while so you can have a chance to look at it. But what's interesting in this slide is that these activities are all standing related. So they range from probably taking a shower while standing, getting dressed, and carrying out household tasks. The next group of activities, as we can see, this is more walking related, and it includes a variety of things to do with the walking surface, walking speed, also lighting conditions, and navigating barriers. Moving to the third group, we can see that this is more of a diverse group of activities that actually includes climbing, stepping, pushing or pulling, and getting up from the floor or ground. So, to conclude, we found that the vast majority of the activities proposed in Singapore were relevant to people living in the UK, which is interesting. However, new activities emerged from the people living in the UK, which will need to be considered in developing our new scale that would be relevant and comprehensive enough for use within the UK context. Talking impact, this work provides invaluable insights to healthcare professionals involved in the management of falls, and also constitutes a foundation for the development of the UK's first balanced recovery confidence scale, which we are at the final stages of developing. So if you or you know somebody who might be interested in helping, please don't hesitate to scan this QR code and get in touch, because we will be looking forward for so many people to fill in our new questionnaire. So thank you very much.
I'm probably loud enough, I think. I'll
Thank you. Thanks a lot for that. It was really interesting. I was just wondering, my experience of asking people if they've had a fall is that often they're reluctant to tell you. So I wondered if you'd thought about asking people if they feel they might be likely to fall or they're worried about falling, which is what I think you're suggesting with this might become, generate sort of inaccurate answers essentially if people are more reluctant. And the second thing I was interested in was around the patient population you selected to question. You included people that weren't unwell and didn't have any health problems. And I wondered if that would have skewed things because they're probably less likely to be at risk of falling as an older population. Sorry, two questions.
No, that's great. I just hope I can remember them. Other than that, no worries. So touching on the first question, which is to do with having conversations with patients, I think it's a communication issue that can apply for many aspects in dealing with patients. So you're absolutely right. I think normalizing and trying to build a rapport with the person to kind of explore, not necessarily directly through asking, even though that can be very helpful about falling, but also engaging in activities. So asking the why behind avoiding certain activities, and then falls might come up later in the discussion. Also, I think normalizing and providing some sort of empathy by showing understanding and talking generally about people who might be experiencing these difficulties so that people don't feel lonely in the journey. And talking probably sometimes about the supporting systems available would be necessary. You mentioned something that is actually interesting to do with fearing to fall. So from a psychosocial perspective, we make a distinction between confidence about regaining balance or confidence about maintaining balance in general and the construct of fearing of falls. So a fear of fall is a bit different from the confidence, albeit both are necessary psychosocial ones. So for the second one, can you remind me of the question, if you don't mind?
It was just about the characteristics of the patient population you chose.
Yes, so you are absolutely right to question that because it's key to understanding the relevance from a perspective. So we did not exclude people having health issues. It's having serious health issues that would deem them dependent, because our work was focusing on independently living people in the community. So people who might be dependent because of a serious health condition would deem excluded as such. But thank you very much.
Thank you. I want to know what's next. So what's next for your study?
So that's actually a great question, because when we ask ourselves, and what's next, are we basically bringing those 27 activities to people and starting to score their confidence in each of these activities? And in fact, while this theoretically would be fantastic, in fact, impact-wise, if we're trying to translate research to practice, something that we needed to think of is usability, which is to do with the length of the prom. So what we already did so far, which is also great and worth celebrating, is that we developed a shortened version of the questionnaire, and we did so by getting back to the experts, and this time we asked them to rank their chosen activities based on priority, and we came up with the most important 9 activities out of these 27 activities. We also carried out interviews, in fact, to talk people through these activities, the wording, how they understand the questionnaire. So we are at the final stages, and the last stage would be field testing, which is asking people, sometimes begging people to fill in questionnaires so that we can carry out the psychometric analysis.
Are you able to share any early reflections on that, or is it too early?
Probably slightly too early now, because it's to do with then the evaluation of the psychometrics, because this might end up with removing some activities and adding others, amending some as well, after what we refer to as factor analysis, just to make sure that all these questions are basically asking the same question without ending up having data that is not as accurate as we wish. But hopefully soon. Thank you very much.
Next year we'll know. Great, thank you. Anything from our online audience, Sarah? No? Yeah, I want to throw.
Okay, this might be a bit of a stupid question, but what are you actually asking with the question? So is it how confident you are that you can maintain your balance while doing the activities?
So that's great. So basically, the question wasn't how confident, because that would be the question of the questionnaire. But this questionnaire, at the heart of it, incorporates the activities, which we refer to as the situations that would provoke the construct. So here, the construct is the confidence. So you are right. That is the questionnaires overall question, or the scales overall question. Then how confident would you be able to recover? Then we need a set of activities that would provoke that construct. So we needed to know then what are these activities, so that we don't end up rating people's confidence to regain their balance in some activities that they don't actually perform in their lifestyle. Thank you. That was really interesting. Off the hook. Thank you.
Can I just share? Yeah, thank you very much. Thank you, Yasid. And thank you all for joining. And now we can break for the coffee break. Thank you.